this presentation will be a tag team presentation. I'm going to give a brief introduction to some of the imaging technologies used to look at traumatic brain injury, and then Dr. Randall Benson is going to talk about some example case studies in looking at diagnosis and other issues related to patient evaluation. So it is estimated that there are about 2 million head injuries in North America every year. About 80% of these are mild in nature, and half of these are occult to imaging. That means that no imaging methodology, CT, MR, PET, are able to pick up problems for these patients, despite the fact that many mild patients have persistent symptoms that will occur for several months after their accident. Our goal is to image these people to determine if the source of their problems can be diagnosed, understood, and treated. So we use a variety of techniques to image TBI patients, including conventional T1, T2, and FLAIR images to visualize edema, susceptibility-weighted imaging, or SWI, to image hemorrhage and decreased levels of oxygen saturation, perfusion imaging to image oxygen delivery to the tissue, diffusion-weighted imaging to determine local cellular changes, and diffusion tensor imaging to map out damage to fiber tracts. Well, here's... It's really delayed. Well, that's fine, because they can see this. So while your system is refreshing here, one of the next slides that you should see are some images showing the veins of the brain. The image on the left is what we call a susceptibility-weighted image, and the image on the right is what we call a susceptibility map. So we use these images to monitor the amount of iron in the brain, the amount of deoxyhemoglobin in the brain, and this is a normal volunteer, so everything looks pretty good here from the vascular side. Now, if we use this same technology to study patients with traumatic brain injury, then we're going to see that conventional imaging is often unable to find something wrong with the patient. So out of that 50% of patients who were occult, we believe that we can now start to see something wrong in about 15 to 20% of those patients. So in the central image, you can see by the yellow arrow that there's been some shearing injury by the septal vein, and in the white arrow on the upper left side of the brain, you can see a hemorrhage by the Peel vein. So although these are not major bleeds, they're still indicative that there was some damage done. So if a patient had been in an accident and then complained of some problems, cognitive or attention problems, and then he were scanned with these normal methods, the doctor might say, oh, there's nothing wrong with you, you weren't even hurt in the accident. But in fact, these images now demonstrate that the person was hurt in the accident. So this can have important implications for the patients who may have trouble working, who may need time off. It may have legal implications for the patient that there really was some damage done. Another example of this can be seen here again by the yellow arrow, and this is pointing out an area of venous thrombosis in a medullary vein, also for a TBI patient. So clearly there was some damage done here. And then we have a very interesting case of blast, where a soldier was impacted by blast and thrown backwards and hit his head. And you can see here clearly in the upper left image the area, the vascular area shown here, that is a representation of increased deoxyhemoglobin, which practically means reduced perfusion to the brain. And on the upper right image, where the phase is showing bright, we can see this is also an indication of in that entire vascular pathway, the deoxyhemoglobin level is consistently high. And in the lower two images, again, you see the damage on SWI, But you also see some indication on T2 that there's been some tissue damage, not just vascular damage. We can take this technology that we call quantitative susceptibility mapping, or SWIM in our terminology, where we can look at the buildup of the iron. And here we can see iron in the globus pallidus. That's here. We can see iron in the form of microbleeds that took place for this patient. So this is a very nice technology that allows us to quantify that information. Oops. Now this is a direct example of this concept to stroke. And in stroke, you can get significant reductions of perfusion. And you can see in the left image, on the left side of the image or the right side of the brain, there's been a significant darkening of the veins, and that means an increase in deoxyhemoglobin. On the SWIM image, the vessels get very bright, and that's because that represents high levels of deoxyhemoglobin. So in principle, we can tell from these images that that patient has a perfusion deficit. This is an example of a 3D movie using this SWIM technology that shows you all the microbleeds embedded in the brain, and you can see the major veins that are surrounding this. So it gives you a nice perspective in 3 dimensions of how significant the damage was throughout the brain. Now we can also compare SWI with perfusion imaging, and perfusion imaging is not something that's being done very much with traumatic brain injury, and it's something I want to suggest we should be doing much more of. Now, if we can't do perfusion, maybe SWI would be the poor man's perfusion substitute. So here you can see in the upper right image, marked MTT here with a red arrow, you can see this green area that represents a reduced mean transit time, i.e. it's taking longer for the blood to flow through that tissue and get to that tissue. And you can see the same area on the SWI shows very dark in this area. Now, after the patient was treated and the embolus removed, you can see a return to normal flow, and you can see a return to normal oxygen saturation levels. And this is a good example of a patient who recovered well and was able to go home and leave the hospital. Now, what if we take this same idea and start applying it to traumatic brain injury? So here you can see clearly in the upper right image that in the mean transit time for this TBI case, just like in stroke, there has been a significant delay of tissue to the brain. And then you can see significant damage in the middle 2 images. And Randy, I guess I could call this a hematoma then? Subdural hematoma. And if you look at the SWIM images, you can see clearly that the areas adjacent to it and even the areas penetrating the whole left side of the brain have increased levels of deoxyhemoglobin. So stroke teaches us a lot how to look for vascular abnormalities, and we should be taking advantage of this with TBI. So I'm going to close with this part of the discussion in looking at 2 other TBI cases where we have significant frontal white matter damage according to the SWI scans. Now, it's really quite amazing here. If you look at the lower images, the flare images, they basically don't show any of this effect at all. Again, perhaps some blood here in the frontal area, but the SWI shows extensive damage in the white matter. And even though we don't have the perfusion information here, the odds are that this would represent perfusion deficit. And in another more subtle case than this, you can see here, again in the frontal left side of the brain, not only evidence of microbleeds, but also darkening of tissue, which is representing reduced levels of flow to the capillaries. And just like in the stroke cases we looked at, this likely represents a whole region of perfusion deficit here that you can first make some hint at using SWI, even if you didn't do perfusion. My point here is that I think we've missed the boat not doing perfusion imaging with traumatic brain injury, and we may find that there's a very strong correlation with these changes in SWI and perfusion. So finally, the final image I have here is an example of a whole brain SWIM image. The green represents the oxygen saturation levels in the veins, and the blue represents the iron content in the basal ganglia. And in principle, if we could image a stroke patient like this, a traumatic brain injury patient like this, these 3D images will show us all the areas that are compromised due to bad flow. So I'm going to stop there relative to these discussions related to flow and oxygen saturation, and have Dr. Benson bring up his slides so we can look at some specific patient cases and also some discussion of diffusion tensor imaging.
Okay, I guess we're on. Okay, thank you, Dr. Haacke. Now we're going to transition to talking about diffusion tensor imaging and using the images in concert with each other. Okay, so very, very briefly, there are two types of traumatic brain injury. One is focal, which refers to there being bruises and hematomas as a result of trauma, and the other is diffuse. And very quickly, because I like this slide more than anything, you can see that MRI is really a one-stop shop. There are many different kinds of images that we can generate from MRI. We think of MRI as being a platform. So for instance, this would be a T2, this would be an SWI image, this would be a flow image. This is one type of diffusion tensor image called tractography, which you might be familiar with. This is a thresholded FA image superimposed on an anatomical image, and these three below are different representations of MR spectroscopy. In particular, at Wayne State, we focus on SWI and diffusion tensor imaging, but as Dr. Haacke mentioned, we're also developing perfusion and spectroscopy. Truth is, diffuse injury is clinically the more relevant or significant type of injury, and therefore we need imaging techniques that are sensitive to diffuse injury. And probably at the top of the list would be DTI, diffusion tensor imaging. And this is an imaging modality that's sensitive to water flow and the directionality of water flow. For instance, water in this glass is largely isotropic, meaning that the water flow, the protons, and the water molecules are free to diffuse in any direction. In comparison to a tube or a vesicle that's much longer than it is wide, in which case the water flow tends to be directional or polarized, and we call this anisotropic diffusion. And what we know from pathology is that axons normally are very long and relatively narrow, and there are many of them. And after injury, such as this stretch injury in a mouse axon, first stage is that you see these undulations or these folds, followed by swelling, and then over time, days to weeks, you start to see fragmentation and what we call retraction balls. And this is fortuitous for us, since we have an imaging technique that is sensitive to water flow. And so diffusion tensor can see changes in water flow. So pre-injury, as we mentioned, is very anisotropic, meaning that that there's one component that's much greater than the other two components, but that changes with injury. And we can represent, we can index the directionality of the water flow using a parameter called fractional anisotropy. And very briefly, this is the equation for fractional anisotropy. And as you can see, the numerator is composed of three terms that compare each individual component to the mean diffusion, and the denominator is essentially the sum of the individual components. And what we also know is that gray matter, in general, has lower anisotropy than white matter does, as you can see with our segmented image analysis. And what we did a few years ago and published in 2007 in a sample of heterogeneous patients compared with controls, we simply looked at the mean or the average, the arithmetic mean fractional anisotropy over the entire volume of white matter for a number of subjects, and we found that this mean fractional anisotropy completely differentiated between these two groups. And in fact, not only did it correctly categorize these individuals, but we found that the degree of anisotropy correlated with an index of injury severity called post-traumatic amnesia, with a correlation coefficient quite high at minus 0.64. Further, we found that if we only looked at the mean FA, that was fine as long as we were looking at higher severity cases, such as severes and moderates. But if we looked at mild cases, we could fool ourselves if we simply looked at the mean FA and didn't take into account age. What we see here is a cohort of 50 normal, healthy individuals, and what we found, as others have, is that there is a decline in the average FA throughout age. So when we do our image analysis, we take into account the age effect and effectively regress out or correct for age, so that we can allow ourselves to be more sensitive and specific. Now, in reality, practically, we use a number of different image analysis methods to improve our detection of brain injury, and in particular mild brain injury. We start with a regional analysis using atlas-defined regions, and this essentially reduces the dilutional effects. That is to say, if we only look at a mean over the entire brain, then it leaves little room for small regional effects. So this is why we break the brain down into effectively 50 different regions. We also do two other techniques that reduce the brain down to even smaller pieces, voxel-based and a tract-based method. In voxel-based, the TBI image is warped into the same space as a number of healthy subjects, and then a voxel-wise statistical analysis is done on the FA. Similarly, a tract-based spatial statistics method orients the white matter tracts together, but only the centers of these tracts are analyzed for the reason that it minimizes misregistration artifacts at the edges. All right, so now from here I'm going to just go through some cases. First case is ZD. This is a severe TBI, 19-year-old man. He was in a car accident where his car skidded on black ice and hit a tree. His GCS, which stands for the Glasgow Coma score, was a 3. 3 is as bad as you can get. It ranges from 3 to 15. So he was in a coma when he arrived in the emergency room. He was in a coma for 2.5 weeks. He was scanned 17 months post-injury. Okay, and what we see is his flare image, one slice of his flare image on the left, showing essentially nothing. And the SWI, which you've already heard about from Dr. Haacke, is showing numerous microhemorrhages throughout his brain. Some of them are oriented in this linear fashion because the veins are oriented that way, and some are more spherical, and we tend to see both types. And what we're looking at now is his DTI image. What we've done is we've done a voxel-wise. Actually, I'm sorry. This is a tract-based analysis, and what we've done is we've compared ZD to a number of healthy controls, and we've from there created a statistical map. We've thresholded the statistical map using a T statistic of 3 or higher. All right, what we're looking at is significantly reduced FA areas, and they're showing up in color, going from a bluish to a yellow and whitish. And we see that he has numerous voxels showing up in color, indicating that he is, or that that these regions are achieving the fairly rigorous statistical threshold. Now, we can also compare across these different brain image types. So, for instance, his FLAIR image again shows very little abnormality, but the SWI co-registered with the FLAIR is showing, as we saw, numerous microhemorrhages, particularly in the frontal lobe. The voxel-based white matter analysis is showing abnormalities predominantly in the left frontal lobe, but also in the right frontal lobe. And the tract-based analysis is showing a similar pattern, albeit more narrow, reflecting the fact that it's only looking at skeletons of these white matter tracts. DTI generally is more sensitive than SWI. DTI also reflects several other chronic degenerative processes. So what we're saying here is that SWI and DTI are complementary methods. They're not imaging the same source of contrast. One is looking at hemorrhage, and the other is looking at abnormalities in the white matter that can occur as a consequence of a number of different processes. So again, we see the FLAIR images showing us essentially nothing, the SWI showing a few microhemorrhages, VBA and TBSS showing not only abnormalities in the cerebral hemispheres, but also in the brainstem, which we don't see in either the FLAIR or the SWI. And we think that these abnormalities in the brainstem may reflect chronic degenerative processes, such as Wallerian degeneration in the long corticospinal tracts. We've also done some studies in former NFL players, and this is a case of a 36-year-old former fullback in the NFL who played in the NFL for 11 years. He had multiple episodes of visual loss after collisions, and the only area of injury that we found in this individual was in an area of the brain called the splenium of the corpus callosum, which is interesting and correlates nicely with him because the splenium carries visual fibers that go from one visual cortex to the other. So nice clinical correlation. Here's another former NFL player. He was scanned at Wayne State. He was also scanned at a magnet in New York at a different time, and we found essentially almost the same exact finding, showing that we have nice cross-site reproducibility between these two magnets. So the finding represents this former player's injury. Here's a mild TBI case. This woman was rear-ended, 43-year-old. She was scanned 21 months post-injury. She was struck by a semi to the rear of her parked car. She did not lose consciousness. And it's important to note this because 90% of the time people with mild brain injuries don't lose consciousness. But she was dazed and she was speaking very slowly immediately after the accident. She suffered a whiplash injury to her neck. She had cognitive slowing. She was stuttering. Years later, she was still stuttering, and she lost some of her fine motor dexterity. She was diagnosed with depression and anxiety, but she was never diagnosed with brain injury until I saw her and imaged her. The first thing we saw in her SWI was a very tiny hemorrhage in an area of the brain that is important for her clinically because this is the deep temporal lobe, and this is an area that carries language fibers. She was somebody who stuttered, and she also had some mild language deficit, so we found that that was a nice correlation. We looked at her DTI, and we saw something we didn't expect, but now we've come to expect this in rear-end collisions. Her corticospinal tract, which is here and here on both sides, was affected fairly prominently, and this is the major motor tract that supplies the limbs, and when we see these kinds of injuries, we expect that we're going to see a loss in fine motor dexterity, and in fact she did. We also are aware that when we see bilateral, or we see injury on both sides of the brain in the corticospinal tract, we're very likely to see emotional discontrol issues, which she had and was quite upset about. Another case is a case of an epidural hematoma. 26-year-old man who was in a high-speed motor vehicle accident, suffered a left temporal bone fracture and an epidural hematoma. He had a left shoulder injury. Symptoms that he presented with were mild word-finding problems and auditory attention problems. Neuropsych, his neuropsychological evaluation showed a high IQ, mild attention, and executive function problems. So our task was to image him. Now his acute CT, which I obtained from 2010, showed a fracture of the temporal bone of his skull, and immediately beneath that, the CAT scan showed that he had what's called an epidural hematoma. And you can see he also had a lot of soft tissue swelling on that side, because that's the side of the head that he whacked very hard. Okay, and we did a 3D reconstruction and a surface rendering of the CAT scan to show precisely where that epidural hemorrhage was located. And in fact, as you can see from this functional map, the epidural hematoma was located in a motor speech area and also an auditory association area. Now remember, his two major deficits were word-finding problems and mild auditory attention problems. So far we have a good correlation here. When we looked at his diffusion tensor map, we found that that he had abnormalities predominantly in the left temporal lobe, or left frontotemporal area, very, very close to the hemorrhage, most likely a result of the compaction and the focal impact to the left side of his brain. In addition, you can see that he's got a couple of other foci of abnormality. So without DTI, we would not necessarily appreciate that he had axonal injury. We would possibly conclude that all he had was bleeding outside of the brain. So this was very helpful clinically. Another case, motor vehicle versus pedestrian. 23-year-old who was working as a flagman for the Ohio Department of Transportation. The semi hit the zone truck that he was working on, going 60 miles an hour, and part of it struck him in the head. He was in a coma for a week, suffered a broken nose, fractured orbit on the left, right knee, anterior cruciate ligament tear, and also had a pneumothorax in his lung. Early on, he was very slow and disinhibited. He had a significant retrograde amnesia for 2 days prior to the injury, so he couldn't remember anything that happened 2 days or afterwards prior to the injury, which indicates a more significant injury. He had 2 months of outpatient rehab, and then he had what his fiance called a remarkable recovery, but he did have residual memory, vision, neck, back, and knee problems. Well, we can see from his reconstructed SWI scan or flare scan that he's got asymmetry from the fracture of the left orbit. He still has some some high signal on the flare on the left compared with the right because of his injuries. And we can see the very, very dramatic hemorrhages that he has on his SWI in the right frontal lobe, the left frontal lobe. So when we saw him, he looked good enough clinically that I really didn't anticipate such a severe appearance on his SWI. And when we compare some of the slices of his SWI to the DTI, we see that there is some overlap, but quite a different appearance. And again, what we're seeing with DTI and SWI is that they're complementary. The DTI, diffusion tensor imaging, gives you areas of white matter that either were directly injured or potentially degenerated or thinned as a consequence of connectivity with other areas that were injured more directly. Now, this person had some language deficits, albeit mild. Language is located in the left hemisphere predominantly. We can see on the SWI a lot of hemorrhaging along the cortex in the frontal lobe as well as the temporal lobe, and we see corresponding abnormalities on the DTI in the left hemisphere. He also had some fine motor problems, and we see why, particularly on the left side. His corticospinal tract is showing abnormalities. Last case, I believe, another pedestrian. She was standing in the road and was hit by a truck. She was hit the legs. Her legs were hit. She was thrown. She hit her head on the asphalt. She had a left skull and basilar skull fracture. Suffered a right temporal subdural hematoma. She also had a fracture of her cervical spine. And this was what we call multi-trauma. Now, just to show you some of the nice correlations, she had virtually no sense of smell on the right, in her right nostril, and we can understand why. The right frontal lobe was damaged. We can see that on SWI. And DTI, the olfactory bulb, runs just above I should say just below the orbital frontal cortex, so it lies just beneath this area, and most likely the olfactory lobe was torn or stripped, resulting in this smell problem. She also had decreased fine motor problems on the right hand, and we can see on the DTI why. She's got hemorrhaging along the motor cortex on her SWI, and we're also seeing evidence in the brainstem that the corticospinal tract was damaged. Furthermore, she had executive function problems or frontal lobe issues, and we see ample evidence beginning with her flare, but also her SWI and her DTI, showing that she's got abnormalities in both frontal lobes. And it's easily seen when we look at all three image types together. So some final words. Multimodality MRI is sensitive to even mild TBI. The key is to show convergent evidence across behavioral, imaging, biomechanical, electrophysiologic modalities. We think the imaging confirms and explains the neurobehavior and the neuropsychological findings. It's also quite useful in a medical legal context where it has been admitted as evidence in court many times, and successfully, and largely because of this good clinical correlation that we see between these imaging techniques and the behavioral and clinical deficits that the patient has. So with that, I will stop. So we have somebody here, Paulo Rodriguez. Hello, Paulo.
It's asking
Are you just using FA? FA can be quite misleading. Well, I'm not sure exactly what you mean by misleading. It's true that there are potential false positives with FA. There are some image processing techniques that we use to try to minimize that as much as possible. And one of the main ones that we use is to use the statistical analysis where we compare. Typically, we use 87 healthy controls, and we age correct so that age is not an issue, and we do a statistical comparison of only the white matter between our index patient and our normal controls. So the question is, can it pick up mild TBI? There's no reference to whether you're referring to SWI or DTI, but I can answer both because we are looking at exactly that. What we find is that people with persistent cognitive deficits or behavioral deficits most often do show abnormalities on DTI. And in fact, SWI is positive in around 30% of cases of persistent mild TBI, persistent symptoms in clinically mild TBI. Turns out flare is also very useful and may be positive in as much as 2/3 of cases of people with persistent symptoms. So yeah, certainly we're looking at cases where individuals come to us with persistent problems. So these are not the people who get better, really quickly. So we're looking probably at a select group, but these are still mild patients that we're looking at.
Study in Coleman male. I'm thinking mild concussion.
Okay.
Mild TBI.
Okay, so mild concussions in terms of mild TBI. Well, most often concussion is used interchangeably with mild TBI. Now you're talking about mild concussions. I'm not sure what you mean by mild concussion, but if that's a concussion where a person is symptomatic for a day or two, I think it's unclear whether our imaging would be sensitive. I think it's likely that spectroscopy could be sensitive, and I think it's likely that perfusion could be sensitive in the first 24 hours. We don't know about DTI, and I think less likely that SWI would be positive. Hopefully this has been helpful for you.
Another question.
Since most concussions are symptom-based in terms of diagnosis, looking to see if DTI or so will show evidence. Okay, I'm not sure exactly what the question is. I think I've already answered that. If the question is, will DTI be abnormal or show evidence in concussions, if concussions are defined as mild TBI, if they're used interchangeably, then I would say that in terms of DTI, we don't necessarily know what the absolute sensitivity is. We think certainly that in persistent symptomatic cases, that the DTI positive rate is high, and we're currently trying to give objective numbers to that. But our impression is that it's probably 90%, possibly higher than that. Okay.
All right, I think we're done here.
Thank you.
Thank you.
And thank you.